Hi, welcome to Facebook Live. Back in the saddle here with my partner, Mr. Justin Westmiller, and we're here to answer your questions. So let's start with the data for today. And no surprises, we are rapidly escalating into a high transmission situation with the virus. Our total cases are nearing 2,000. Total hospitalizations are over 200. That's cumulative, and our cumulative deaths are 65. So we are still not seeing a great burden on our hospitals, although some of them are reporting increased activity. And some of them are reporting pulling out their plans to assist and adjust with more COVID-related capacity, beds, et cetera. We have the vast majority of people recovered, but we have, I do believe, close to 800 active cases at this time. And as I always say, every case we know about, there is probably 5 more. I've read as much as 10, but probably, you're right, between 5 and 10 cases that we don't know about. So you do the math, that's a lot of positive infectious people, and which is why now is the time for us to become super vigilant. So our average number of cases today is close to 50. We have a testing positivity of 7.7%. And there is been a steady increase in both of these numbers now for the last couple of weeks. Next slide. So this tells it all. This mirrors a lot what the state data looks like as well. We are not a low incident community. There are a few counties that are still kind of plugging along, but we are escalating at a rapid rate and have far exceeded the peak amounts of transmission that we saw in the spring. There is, as you can see, a steep incline of that curve. And, you know, we talked about a lot back in the spring about flattening the curve. And there's a great deal of discussion at this point whether that can actually even be done, as opposed to hoping to just see the curve at this point plateau and come down, at least to a point that is manageable. As many of you understand, and I've said before, new cases are typically followed by several weeks by more severe hospitalizations, which are followed by several weeks with deaths. So this rapid escalation of new cases would suggest to us that in a few weeks' time, we're going to be seeing more individuals who require more medical care. And probably not a greater percentage of people, but when you have a lot of people, that percentage that's unchanged is a lot more people. So this next graph shows the testing, and you can see our testing has bumped up in the last couple of weeks. That is not because we have more testing available, it's because more people are seeking testing. And that's because more people have been exposed or know somebody who has an infection, and then they reach out to get testing as well. Our positivity rates are also rising in conjunction with the increased testing. And so we'll touch on the issue of, well, are more tests just because are more positive just because we have more tests. And we'll talk about that a little bit more. Let's finish the graph. In our dashboard, where you can see the cumulative and daily amounts, I do want to mention that there's been a considerable amount of discussion over the past several months about how people would like to see more granular data from our county, either down to the zip code or the township. And we have always hesitated because there are some smaller townships where the population is so small that presenting that information would be a violation of personal health protection or personal health information violations. However, we have reached a point where pretty much everyone has had many, many cases, and we are developing and should have available very soon kind of a color-coded map where you can see in the past 2 weeks, where not cumulative here, because again, that's not important. What's important is in the past week or two where these cases seem to be spreading most rapidly. And again, that happens because people spread it to each other. And it is a reflection on what people are doing in those communities. So I think it'll be helpful when you see that. And surprising, it's that actually the initial preliminary map that we looked at today was not Port Huron, is actually some of our more rural, our western areas that are getting the most per capita transmission. So coming soon. Watch our website. I'm not sure exactly when we'll have that up. Justin, do you know when that'll be ready? I'm sorry, Brandon. Next week. Okay. Okay, so let's get to your questions.
Okay. Can everybody hear me?
Yes.
Can you hear me? Okay. We have quite a few questions already. These are from 2 that came in from last night. We'll start with that. Since the recent spike over the past month or so, can you give some idea to the percentage of symptomatic cases versus asymptomatic? And are the bulk of new cases from large gatherings?
I don't have the symptomatic in front of me. I apologize. I'll get that information. Hang on.
Right now, 85% of people.
Okay. Gatherings. So
Are right now reported about like 7%
okay. So we have that broken down. And I think that's something else that we can continue to break down. That is reported to us, or we review that on a pretty regular basis. So about 85% of our known cases are symptomatic, are reporting symptoms, and approximately 7 or 8% of those are reporting large gatherings. But we also know that some of those are exposed to travel, which you could kind of put that together with large gatherings, workplace exposures, which are gatherings. So it's across the board, and there's no question. And how much is no exposure known? 17%, I believe, is what I saw earlier. So as much as 17%, maybe closer to 20%, really don't know where their exposure was and don't report to us an exposure. That tells us very, very simply that there's enough exposure, there's enough virus out there that you can get exposed pretty much anywhere and not really know. So.
Okay. Next question. Someone wrote that their concern was with the procedures at one of our local hospitals, and they've seen things change over this COVID time. And they're wondering what are the procedures supposed to be for the hospitals as far as testing goes, COVID testing with patients?
There are no rules governing whether a hospital or a medical provider tests or not tests. These are best practices. They're best practice and guidelines have been published by different national organizations, but our hospitals make those decisions based on internal needs, what type of capacity they have for their testing, what the community spread is, and what their inpatient and outpatient situation looks like. So it will change. It has changed. It's going to continue to change. And a lot of it has changed over the last several months because of testing capacity as well as the community spread.
And Doc, I think also that things are always changing with this. And that's why we continue to ask the community to be very flexible while we work our way through this. It's not, like you said a lot of times, it's not going to be a short duration issue. This is going to be a long one. So we just need to hang on and understand that there will always be changes.
Well, and there's risks and benefits to everything. For instance, when a hospital is requiring testing, many times that results in both necessary and quote unquote elective procedures being delayed. And what we know about that is that also has an impact on the well-being of the community. We see elevations in mortality rates and morbidity rates from other conditions other than COVID because people aren't getting the care they need. So you have to balance that from trying to shift everything COVID away to the benefit of having a healthcare facility that's still providing all of their services. Now, we don't hope to see a complete shutdown of elective surgeries and hospital care because there was an untoward result from that. I think we can do it smarter this time. I don't know that we won't see some shifting of what we do, but we can certainly do it a little smarter without shutting everything down.
Okay, next question. Do you have to test negative after you've been positive in order to return to work and school? If not, what is the reasoning for that?
So we talk about this a lot, and the simple answer is no, you do not need to test negative, because there has been ample research and knowledge of this virus to know that after a certain period of time, after a clinical period of no symptoms and a certain number of days, that the likelihood of you still being infectious is virtually zero. So we know that. So we know that 10-day rule works for almost everybody. And there are certain people who are immunocompromised or chronically ill that take longer, but they're going to stay ill longer. So that's why we use not just days, but also clinical feelings, how people feeling. So we know that's the case. We also know that after a 14-day period of exposure, the likelihood of you having an infectious, the virus replicating and you being infectious, again, is virtually zero. So those days are very solidly vetted in science and what we know. They're not perfect, because people don't always know when you have that last exposure. It's not perfect. But the other side of that coin is these tests are not perfect. There are, for instance, a fair number of people who continue to test positive long after they're no longer infectious. The viral particles persist, and these tests are so sensitive, picking up these fragments of DNA, that they continue to be positive well beyond the infectious period. And that, of course, delays reentry into the workforce and a whole lot of other terrible things. So that whole idea of retesting, although it was a great idea, it didn't work in a practical way. Now, there may be circumstances where retesting is recommended by your healthcare provider or others. That's great. But for the vast majority of us, the time frames are adequate, and they resolve the issues of false positives, as well as the fact that now a lot of people are relying on antigen testing, and they have a very problematic issue with false negatives. So especially during times where you have very small viral burden. So the guidelines from the CDC are there because it's best practice. It's the best information we have, and it allows the most people to function and return to work. So we really want to discourage people from requiring repeat testing, negative testing, before someone returns to work or school or a situation, okay? It really isn't needed if that person has fully complied with the times necessary for the quarantine or isolation.
Okay.
I hope I answered that well enough.
What is the reliability of a COVID test?
Depends on the test, and it depends on when you have the test, and it depends on who took the test. Kind of depends a little bit on the lab that you send the test to. So in general, we do consider the PCR testing, the molecular testing, the gold standard. If done correctly with a trained individual who knows how to collect the specimen, and done during a time of infectivity, it can be pretty reliable, as 99.8% reliable. Okay. If you don't take the specimen correctly, or you're doing it at a time that there's well before you start replicating virus, it can be negative, even though in 2 days you're going to be positive. So you have to consider tests in the context of the full situation. Another important area, and I guess we can talk about this, is the positive predictive value of a test, which is kind of a statistical thing, improves as the prevalence of the disease increases. So back in August, when we had low prevalence, these tests tended to be a little problematic. You could get positives and negatives and not really sure. At this point, when we're seeing more and more positivity, I would say a positive test is a pretty predictive that you really do, in fact, have COVID. And a negative test is pretty good, except if you think you have COVID, we want you to be really careful. We're more likely to see false negatives at this point than we are false positives.
Okay, next question. Do you see the schools going completely virtual soon?
Yes and no. Okay, so we have, as you saw, that curve. You like that? Yes or no? You see that curve, it scares us all. Throughout the state, we're having a lot of conversations about this. Here's what we know, though. Number one, kids do better in school. All right, we're not gonna go through all that, but we all know that many children do much better in multiple ways if they have in-person learning. And so, we want to keep our kids in school if we can. Number two is we are not seeing, either in St. Clair or within the rest of the state, we are not seeing a lot of transmission within the schools. And we do this by contact tracing and case investigations, but people, quite honestly, at this point, are much more likely to get infected outside of a school setting or after they have left the school building than within it. And that is true for us. It's been true for us all along. It remains true at this time, even with these high rates. Now, we're going to watch that. And if that becomes a problem, we're going to have to rethink this. But as long as a school technically is a safer place to be for these kids, plus it's a better place for them to be as far as their learning and their social and emotional well-being, then I think we're going to lean towards letting these schools exist. But we also have to consider the workforce there. And that's an issue as well. We're having the same situation with teachers as we are with students. We're just not seeing a lot of transmission within the schools. So being in a school setting, even for teachers, is not a more dangerous situation than when they go home and decide to go to a grocery store or a restaurant or some other congregate setting. In fact, because our schools are doing such an excellent job, kudos to our schools. They are really trying hard to follow those risk reduction strategies, right? I think in many cases, this is a place where you're least likely to find transmission in our community, is in our schools. And so if I can say that fairly confidently, and I feel comfortable that the data is supporting that, I'm going to continue to support our schools trying to do in-person learning.
And I'd like to throw in too that we are in constant communication with all of our school districts in the county, both Dr. Mercatante and I. And assuredly, you can operate knowing that everybody has both the staff and the students, best in mind.
Now, it might be needed to take breaks. Okay, that's something as we look at this. Breaks are certainly something that might be in our future, but just to cut it off and say no more, I don't think we're in that position yet to say that that's where we're going.
Okay. Next question, excuse me. This person says, am I remembering correctly that the 7% statistic was a number that in the past you referred to as a point in which you would be looking at some different practices or regulation changes?
No, you remember that correctly. In fact, I think I said after over 5%, I'd be concerned. There's no question now we're in a position with this kind of positivity that we can fully expect to see ongoing increases in cases. When we were below 5%, I was kind of hoping we could see a plateau or a stabilization. But now that we're in this positivity range, we're going to see increases. And so, yeah, that is the reality. What do? Well, we've become more aggressive with enforcement. We have already in the health department had to change our operational needs and capacities because we can't keep up, which means we're going to have to rely on all of you to know what to do. We'll go through that again, I'm sure, at some point. But you're probably not going to get a call from the health department if you get a positive test, unless you are under the age of 18, in a congregate setting, or in a situation where we're associating you with an outbreak, or a situation where it could be a super spreader event. So that's an issue. Our advice to people is definitely going to change. Stay home. This is the time to stay home. This is not the time to have parties, and what a terrible time to say that around the holidays, but this is not the time to have parties, even on your patios. This is not the time to bring multiple families together. Will you see laws passed to kind of do this? I don't know, but I can tell you this, they don't work. They didn't work last time very well, and I don't think at this point they're going to work. So what we want to do is make sure that people do what works, and businesses, if they're overwhelmed with infection, will probably need to close for short periods of time until the infection clears out of their staff. Those might be 14-day periods as opposed to like you're just closed for good. So we're going to be looking at strategies like that. And we're also going to be looking at, so we can no longer do case investigations and contact tracing to try and draw that circle. Remember, we talk about the circle and trying to make sure that we find the circle and stop the spread. think we're past that. So now we have to think about what are the most important public health approaches that we can take to trying to reduce the risk of this and get us all through this. And those are conversations we're having daily at this point. So you'll know when we make those decisions.
Doc, another question was, where or what is the reason for the rapid increase of COVID? Where's it coming from? Are people meeting in the groups? Are individual people just getting symptoms and then are COVID positive? So,
right. So as I said before, the breakdown is kind of all over. I don't think I saw anything over 20% as a relationship to an infection. Am I right, Brandon? Yeah. So it's from all over. It's from travel. It's from their homes. I would say home contact is probably one of the more common ones that we see. Mom and dad get COVID, perhaps from a workplace, and then the kids get it and grandma gets it. Healthcare providers are still in there. Right. So there's the problem. So we reach this critical mass, right? We reach this point where for every person that's infected, we're seeing 1.2 people getting infected. This is kind of close to what the state's saying as well. I think the state's saying 1.5. So as long as we're over 1, where every one person is infecting more than one person, we're going to see this increase. And then you just reach that critical mass where it becomes exponential, because each increase is more and more people. And that's what we're seeing now. So it's math and it's science and it's virology. This is the way viruses work. They go from person to person. And when you have an entire population that's vulnerable, as we are, then the entire population is the incubator, and it just starts to spread beyond control. The only control mechanisms we have at this point are distancing. I'm going to start saying physical distancing too, because not social distancing, because it's the physical distance that's important, not the fact that you're not talking to people. So it's the physical distancing, the masking, and being really conscientious about hand washing and not going out when you're sick and when you have symptoms. That's all we got. And it's unfortunately not probably quite enough.
okay, next question. I've had friends being told after they test positive that they can be positive up to 90 days. What's up with that?
Well, that goes back to the positive tests that we were talking about, how some of the PCR tests can remain positive for a prolonged period of time. So as a general rule, the health department has had to use criteria so that we don't count people multiple times, because some people, they get positive tests and they go out and they get tested over and over again, and they're tested. So we don't want to count them as multiple cases. So what the state and the epidemiology has guided us to do is not to count a second positive test for an individual until they've gone beyond the 90 days. That's just a line they've drawn. We know that people can get reinfected. We don't know how common it is, but we know it's happened. And so if you get tested within a 90-day period, you will only be counted as one case. If you get tested and you're positive again beyond 90 days, then you'll be counted as a second case. And that's just, it's definitions that we use to keep track of our epidemiology.
Okay. Next question. Are parents contacted if their child's teacher tests positive? And would the entire class meet virtually during that quarantine time?
So the schools are required by law. Justin, help me out here. They are required to post all positive cases associated with their school. Staff, janitors, visitors, students. They're required to post. Now, they're not required to post who it is. I believe that's right. Now, some are.
They're not even allowed to post.
Yeah, that's true. That's true. They wouldn't be allowed to do that. So you will know if there's a positive individual in your class, and you will know that if that individual, if your child was exposed to that individual, because you will be contacted directly by the school and by us, that your school had a close enough contact with that individual to warrant quarantine. The rest of the school will just be notified in general that there's a positive case, and if they haven't been notified to quarantine, then they're just notified so they know. But But it's important to know that just because you have a positive teacher does not mean the entire class is quarantined. Our teachers are doing a pretty nice job about staying away from their kids, plexiglass, things like that. So we're very critical of those cases and trying to make sure we understand what that risk really is. What was the second part of that question?
It was.
So they'll meet virtual if the school decides that there's not enough staffing or students to warrant an in-person learning. And that's a school decision, ultimately, based on a lot of the conversations that we have. We have not had that situation yet, I don't think.
I don't think we have.
Maybe briefly. Okay.
So Dr. Mercatante, Justin,
I just want to, can I just make one statement real quick too?
Go ahead.
So just understand for everybody that the school districts are doing everything they can to make it as safe as possible. Like I've already said, if they have a positive case, such as a teacher, they are for sure making sure everybody does the right thing. They're getting the classrooms cleaned. They're backtracking and figuring out all the touch points for that individual, and they're working through the correct processes. So, this isn't just somebody's sick, we'll move on from it. There's a lot of work that happens in the background to keep staff and students safe.
Yeah, and I just want to say too, we connect the dots. We really try hard to connect, and that's where one other area of the school's cooperation with us has just been phenomenal, because we work together to connect the dots, to try and decide, do these individuals meet on the playground? Do they meet in the cafeteria? Are there other situations in the building besides obvious classrooms? So that if we start seeing a pattern of positive cases, we know, we call it, of course, 2 or more as an outbreak. But if we know that the pattern is related to the fact that they've exposed each other within the building, that's in-school transmission, and the conversation will change drastically as soon as we have a sense that that's happening. And that's what I would mention earlier. We have not found yet at all in our schools. We've had, cases that we can all clearly track back to where their infections were associated with, outside of the school buildings, outside of the classroom environment.
Okay. It's almost 4 and we have a lot more questions. So keep going.
Yeah.
Okay.
You okay, Brandon? Okay. Brandon,
everybody okay? All right. Next question. How long is someone infectious?
So someone is infectious. We count 48 hours. So scientifically, the virus seems to shed most just before symptoms begin and shortly after the symptoms begin. So in a broad way, that is when the virus seems to shed the most. So we know that this period of time before you're actually sick, you can shed a lot of virus. So we are using 48 hours. This is a standard that's been established through the CDC, and I think really throughout most of the world. 48 hours prior to the onset of symptoms, and up to 10, and then 10 days after. Virus is shed at the beginning of that period, and then it drastically reduces the shedding more and more as that time goes by, which is why we're comfortable with 10 days, because by 10 days, there's virtually no shedding. Even though a person can still feel sick, and there's a difference between recovery and viral shedding. And that's been talked a lot about in the medical community. This is not an infection. If you have a moderately severe infection, that you're going to feel better many times in a week, sometimes 2 weeks. Some people feel poorly for several weeks. Feeling poorly is not the same as shedding virus and being infectious. And that's because this virus is having a very unique impact on our bodies and our immune systems, and it causes this inflammatory response. It's very unusual and unique. So there's more going on that end, but it's not the same necessarily as staying infected.
Okay. Next question. Does the test have to be done in both nostrils?
I believe that's the standard of care. And I think that is the standard that's recommended. And that's because you want to have the most possibility of collecting enough virus to be detected in whatever test you're doing. I know when we do ours, our staff are having us do 3 twirls on the outside of our nose, then resting it against the inner septum for several seconds, and then doing the other side the same way. That's the standard we're using, and I'm assuming my nurses are the best at this. And I would say they are. So that's the standard I would assume is considered the best.
Okay. Next question. Is there a website that shows if your workplace has any cases of COVID? If so, what is it?
I think the only thing is the Outbreak site, right, on the MDHHS. And so if we have a workplace or a congregate setting that has more than 2 cases, it is reported on our SIP on Thursdays, and it ends up on the state website the following week. But it won't be listed by name. That's a very good point. It would be, it will be listed on the type of thing. So the best way of knowing if your workplace has a case is they are required, in fact, to tell you. I do believe. I think that is a part of the MIOSHA requirement is employers are required to tell their staff as well as their clients and anybody who's in the building that there was a case. So your employer should be notifying people if there are been cases in the building. And we guide them with that as well, and we try and provide them the best information. But that's the public site, thank you for reminding me, is not listed by the facility name, just by the type.
Okay. Next question. We have a little static going on, so I'm not sure why. But
Justin,
is the mask mandate still going on? People have seen places like grocery stores, etc., that they haven't been wearing masks.
Yes. Yeah, so I'll take that one. So absolutely, the mask mandate is still in effect. Now, it's different from when the governor released an executive order. It now falls under both MDHHS and MIOSHA. They both have created rules, one for the workplace and one for the public. But the mask mandate is valid and standing.
Okay.
so if you are in a place that you notice there are lacks of masks, I'm going to go back to the fact that you need to report that to either the website at the state, the MIOSHA website. We can list those numbers again. They are also on our webpage, are they not, where people can file their complaints. We want to know about them as a health department. We investigate all of them. We send them letters, and then we can move towards progressive enforcement based on the situation.
We do have a fillable complaint form on our website too.
Great.
Okay, next
And it's
question.
more important, I just want to say too, if we get multiple complaints, I tell you, it goes to the top of our list. So don't hesitate to let us know what your experiences are.
Next question. With college students coming home for the holidays, will public schools possibly take a longer break to try to keep transmission down?
Justin?
So I will say that there are conversations such as those taking place all over the county and within our meetings with the public school leadership and all school leadership. So I think there's more to follow on any sort of break that may come, but it is also a valid concern that we have college students returning, and that could potentially raise some additional spread of the virus. So we are talking about that, but we don't have anything to report out yet.
Okay, thank you. Next question. Are we also seeing a lot of influenza in the county at this time?
No, not yet. So we have weekly surveillance reports that provide us with that information, and we're well below baseline at this point with influenza. So we'll let you know when we start seeing it tick up. So this is, in fact, best time to get your flu shot. Okay, we want to get your flu shot at least 2 weeks before we start seeing it in the community, and usually appears sometime in, it can appear as early as October, but typically it's December, January, February, depending on the year. So please go out there and get your flu shot.
Okay, next question. If someone has regular cold symptoms, should they still be tested?
Yeah. So what's a regular cold symptom? I guess I struggle with that. I would say if you feel different than your normal baseline, okay? So some people have kind of chronic allergy symptoms or whatever. So if it's the same old, and you know that you haven't had any real high risk exposure, I wouldn't say rush out and getting tested would be on the top of my list. But if you notice a change in your symptoms, from your normal, I think a test is warranted. As we know, a lot of people have very mild symptoms, and knowing that you have COVID provides you a lot of information that I think will help you make those. It's hard. It's hard to stay home for 2 weeks, right? Or 10 days. It's hard to tell your employer, look, I really got to work from home. But if you know your test is positive, it makes that conversation a lot more straightforward. And the other problem we have is people wait a few days. They're waiting 2-3 days to decide to go get tested. And then they go and it's positive. And then you have all those backup days where you were clearly sick and infectious that we have to worry about. So we want you to know early on what your status is so that you can separate yourself from your coworkers and your friends and your family.
Okay. Next question. If someone gets COVID, is there medication that can be given to them or therapy in their home setting?
No, not yet. We do not have an early antiviral treatment. We have some treatments available for hospitalized patients. They're remdesivir primarily in the steroid, and some protocols now that have helped reduce mortality. But there is at this point no medication that's available for early treatment like we do with flu, right? You know that. So if you have a flu and you get treated within the first 72 hours of your symptoms, those medications drastically reduce the severity of can reduce the severity of your infection. We don't have that for COVID at this time.
Okay. Next question. So many believe that COVID has mutated to become less severe. Are you finding any truth to this?
No, it's not mutated to be less severe, but it may have mutated to be more contagious. So I just read something on the World Health Organization site and the Johns Hopkins site that suggests that this mutation has primarily now 99% of the world virus has this, and it really just it's a spike protein mutation that allows the virus to be more readily spread. I think the reduction in mortality is twofold. One is younger people for a real good chunk of time had this, were the primary reservoir for this infection, and young people just don't get as sick from this for reasons that we're not quite sure about. And then the second reason is we have gotten better at treating those most severe infections. Those like hospitalized people, we're just better at knowing what to do with them. But we are going to see more mortality. We're going to see mortality go up as the numbers go up because, again, it's just a simple proportion of the number of people infected. A proportion of those get sick enough to need hospital care, and a proportion of those will go on to die. And that proportion changes based on age and comorbidities, but those have not changed dramatically.
Okay.
This person, our mortality rates are going up. Go ahead.
This person wants to know that if we go into a business that's reported without alerting them ahead of time, do we do that?
I don't understand the question. Sorry.
So what they're asking is, does the health department, environmental health or whatever, do they make visits unannounced to businesses that get reported?
Yeah, we sure do.
Okay.
Yeah, we have limited staff and limited capacity. I'm going to tell you, I don't have my staff out there pounding the pavement, but we absolutely do have some staff that we send out to take a look at things. We want to know once we get a complaint, we just can't rely on a complaint to take enforcement. I mean, we really do need evidence of that complaint. So we try and go out and get some firsthand exposure to it as well.
Okay. Are bars that do not serve food required to gather contact information for contact tracing?
Take it, Justin.
Yes, they are. So every establishment, whether you're dining or drinking, you are required to leave your tracing information. And again, I think a lot of our businesses in the county are doing a great job. They've turned it into raffles and other things. Nobody is using that information to track you unless, for instance, there's some sort of contact issue, and that's the only time that anybody will be referring to that information.
Okay, last question on the feed. Oh, go ahead.
No, I was going to say, hopefully what that new rule will help us with is not have to put out these broad press releases that say, okay, everybody that went to this restaurant on such and such day, be worried about. What it'll allow us to do is directly contact individuals and know those people know specifically, because it causes a lot of panic to say, oh, you know, how many restaurants have we done this for now? And that's why we do it, because we don't know who's been there. So this will hopefully allow us to be a little bit more specific about those contacts.
Okay, so it's 4:10. We have one last question on the feed. Marlette Hospital made the news with a staff outbreak. Are you aware of any outbreaks in St. Clair County hospitals?
I don't think so. I know we have all of our healthcare facilities have had cases, both with staff. The last report I had with our hospitals, I just spoke with them on Tuesday. They all reported that those cases were unrelated to transmission within the hospitals, very similar to what our schools are experiencing. So people are getting infections from their lives, from what they do outside of their workplace, and go to work and then are identified. So no, at this point, knock on wood, I gotta say, I think our hospitals are prepared for this. And I mean, they were the first round, our hospitals and our nursing homes. So out of all the facilities we have, they're the ones that are most prepared to respond. They know what to do.
Okay. All right. And one last question that we've been getting here on our phones. People call and they want to know why they weren't called if they feel they were a close contact of a case. And so I guess, can you explain the difference between a close contact and a contact of a contact, and why some are called and why some aren't? That's a really
Well, first of all,
big
we
question.
can only contact you if we know about you. And there's a